relevant to the modern time as the incidence of infertility is rising, and all of us must know about, must have the primary knowledge about what is the incidence and what are the causes of infertility, so that many of them are preventable, which can be prevented. So we have Dr. Ritu Jain. So I invite Dr. Ritu Jain for her talk. And before that, I will just request all of the participants and delegates to please keep themselves muted, so that there should be no disturbance. Thank you. Thank you very much.
So, can I share my slides, Dr. Pawan?
Yeah.
Yes, ma'am, please share.
But we publish only the priority batch. We publish standard operating procedure which are there.
I am getting some disturbance from the previous this thing. So
Pathogens are actually
only one talk can go on, Dr. Pawan.
center. Klebsiella, Acinetto, and Staph are all.
So because if I start speaking, I think now can I start? Yeah. Good evening, everyone, and dear friends. First of all, I must thank IMA Haryana to give me this platform to talk about the topic rising infertility and the treatment approach. First of all, when Dr. Pawan told me to talk about, I'm not able to move my slides. Yeah, first of all, when Dr. Pawan told me to speak on this topic, give me 1 minute, please. So I was wondering that can infertility be really prevented? Because all the time we are treating infertility. So zooming in and coming out of this Zoom gave me some interesting facts. It is that the macro environment really affects the micro environment of the uterus and the follicle, and it has great impact on the infertility. And see this today's newspaper in Indian Express, even the government has raised its concern about the adulteration in the food, which is causing infertility and rising incidence of cancers. So much so, there is advisory not to use paneer from the market, and there have been ethylene oxide and thiocyanate added to mustard oil and also to the spices in Indian blends. So just see that if these pesticides and these chemicals are so hard to stomach, where there's so much of acid to digest, how they must be behaving with the germ cells which have to recreate. To my surprise, infertility has just doubled in the last 2 decades. From 6%, it is 17.5%. So it is really a cause of concern to all of us. And it is not only female who is responsible for infertility, male is equally responsible, almost 50%. Amongst the causes of female infertility, ovulatory disorders is the maximum incidence because of delay in planning the pregnancy, followed by tubal obstruction, endometriosis, unexplained, which includes the uterine factor also. And also the male infertility has risen, mainly the male infertility has risen, mainly the unexplained, followed by varicocele, and then hypogonadism, urogenital infection, undescended testis, and sexual
Good
dysfunction
evening, ma'am.
a lot.
Good evening, ma'am.
So is it still a social disease or stigma or actual delay for project fertility we are dealing with because of the career options? Definitely it is linked to the mental well-being, peace of mind, and one's growth. So considering the time of planning in pregnancy, does the old definition of infertility holds true, which says that 1 year of unprotected intercourse, only after that we are supposed to investigate? This is as per new ART guidelines 2022. What if a couple comes to us at the age of 35 or 40? Do we wait for 1 year and let her ovarian reserve exhaust? Definitely shift in reproductive calendar by years is leading for reproductive specialists to deal with more and more cases of poor ovarian reserve. Because of premarital fashions, increased incidence of pelvic inflammatory disease and non-functional tubes is happening. Then, in particularly in NCR, in metro cities, there is performance pressure, projected timelines, work schedule, and time meeting time, which does not allow a couple to have relations only. And aging uterus, which should have been ideally filled with baby in time, is full of myomas and adenomyomas with advancing age. And of course, the incidence of azoospermia and sexual dysfunction has increased. With decade shift in planning, there is also change in the obstetrical pattern, also increased chromosomal abnormalities, increased miscarriage rate, and failed fertilization. And this has led to a real new branch of obstetrics, which is high risk obstetrics, and which deals with not only the chromosomal problems, increased miscarriage, but also the maternal morbidities like diabetes, hypertension, and more chances of cesarean section and increased probability of increased maternal mortality. So, 1 minute. Not able to move my slide. Yeah. So the time is ticking very fast. The time clock is ticking not only in the brain, leading to altered circadian rhythm and changing of the gonadotrophins. That means decreased gonadotrophins and decreased sex hormone. And then it is also clicking in the uterus also. Uterus also ages and it becomes less receptive to hold and allow the embryo to grow. No longer we are dealing with young pregnant women, rather day in and day out, the obstetrics is changing from young to 40 to geriatric obstetrics, making it really high risk. Changing circadian rhythm, changing work pattern leads women with less number of egg left, and time it is ticking like a time bomb, and they really have so much of anxiety that we really have to resort early to procedures like IVF or ICSI. Now, coming first of all to first important thing, that is advanced maternal age, which we know leads to decreased quality oocyte, decreased number of euploid embryos, that means healthy embryos, and more number of miscarriages. This is a beautiful Poseidon criteria which stratifies the low prognosis patient, and it starts at 35. And this is actually nowadays the right calculator, that one starts the fertility at 35, how much are the chances of healthy conception and miscarriages. So as the age advances, we see in this the fertility decreases and miscarriages increase, because age-related AMH decline is sharp after 35, and it is here people start planning. So if we see at this chart, we see that the peak fecundity is between 23 to 28 years of age, whereas the starting of fertility in pregnancy nowadays is shifted to 35 and 40s. Of course, we get these results, decreased live birth and increased miscarriage. Many years back, paper published, Microsoft gave an article, freeze your eggs and not future. That was highlighted, but plan and time was not even mentioned. So that is the result. Even now, the social freezing has not come up to the mark it should have been. Now, coming on to the causes of female infertility, we know it can be there in the ovaries, it can be there in the tubes or uterine anomaly or some infection, or endometriosis, and many more. So can all the causes be prevented? Most common is PCOS and metabolic syndrome, almost 20%. Then premature ovarian failure, actual incidence is just 1%, but because of delayed planning, it reflects as 10%. Uterine factor is one of the major causes, and it is due to chronic infection leading to chronic endometritis, which makes the uterus less receptive to hold the embryo. Endometriosis, because of the environmental factor and altered immune function, has increased. Same way tuberculosis, which affects the tube, uterus, and the whole genital tract. Unhealthy diet and lack of exercise is the routine pattern which affects the whole endocrine metabolic system, and of course the workplace hazards. Now, amongst the male factor, we know that it is the environmental toxins, smoking, radiation, advanced age, obesity, nutrition deficiency, varicocele, STDs, and then age-related things like diabetes, fatty liver cancer, and medications for blood pressure or something which affects the male fertility. So we all agree that male infertility is on rise and sperm count and number is on decline. And there is lot of oxidative stress, which is due to probably low physical activity, high fat and coffee intake added by stress, low fruits and vegetable intake, and high temperature, increased sperm DNA damage, affecting number, motility, and morphology. And of course, the other things, the habits, the sonabad, junk, and obesity, all lead to infertility. Mention about the hernia surgery and the chemotherapy, they also lead to infertility in male. So what is the need of time? It is the right counseling at right time, and which I believe probably is the adolescent age, or any medical event if happens should be put on the paper. So it is the faulty eating and disordered lifestyle stress which leads to aggravation of most of the factors. So it is this endocrine disruptor word or the junk food which has led to so many problems. As we see in this, it leads to decreased ovarian reserve, follicular atresia, decreased estrogen levels, decreased gonadotrophin levels. It is associated with endometriosis, decreased endometrial receptivity, decreased testosterone and androstenol levels, and increased insulin resistance in PCOS. Not only this, these compounds like dioxin-like compounds, biphenyls, DDT, other pesticides, plasticizers, and bisphenol A, they lead to lower oocyte competence and decreased gonadotrophin levels, and it leads to higher immune activation. In short, it interferes with the endocrine system, adverse developmental and reproductive effects. It also affects the neurological and immune system. What about cosmetics? Most of the girls and young boys are in the habit of using them day in and day out. It definitely leads to precocious puberty or sometimes congenital malformations, endometriosis, PCOS, impaired ovarian function, and altered and reduced fertility. Endometriosis is found to the tune of 20% in cases of infertility. And of course, the whole environmental factor leads to altered immune phenomena. It is very important to know about endometriosis because most of the time, these young girls, they present to our adolescent health clinics or pediatricians with symptoms of pain abdomen. And though we say that this disease is benign, but it is the most infiltrative disease which accompanies a girl or a woman throughout her life. And it has to be diagnosed and suppressed well in time because this may really blacken her reproductive years with various colors of cyst. The patient, the girl usually presents with phenomena of pain abdomen or absenteeism during her periods, or sometimes passing pain during defecation or painful urination. So these are the symptoms which pediatrician or the adolescent health specialist has to really identify and have a third eye to think about, have a third eye to look for endometriosis because the symptoms vary and it has a long term impact on fertility. More importantly, the symptoms do not have correlation with the severity or the grade of the disease. There may be a severe disease presenting in the mild form or mild symptoms harboring a severe disease. So, what should be the line of treatment? Is giving NSAID is sufficient for these? I think it is better to have a consultation with the colleague gynecologist as well. And it is important to give cyclical hormonal therapy, because that only will induce the low estrogen state by inhibiting the ovulation, and less bleed into the peritoneal cavity due to retrograde menstruation, and that will only halt the progress of disease. Because if it progresses and it takes it full blown shape, it is infertility, which is really difficult to treat, where surgery doesn't have much role except it is large painful endometrioma. Most of these patients need medical associated reproduction, meaning thereby these patients, depending upon the grade of endometriosis, will need either IUI with ovarian stimulation, that is in grade 1 and grade 2, or if it is grade 3 and grade 4, most of them need ART, that is IVF or ICSI, and that too is early. So specific protocol cannot be recommended. I will just touch upon the treatment part because it's a very huge subject. So any protocol, antagonist or agonist, can be offered. And most important is to reassure the female that treating with ART will not increase the recurrence or incidence of endometriosis. And during retrieval, very important to use antibiotic prophylaxis and avoid touching endometrioma at all the times. And surgery is not to be done prior to ART. Only ART as a part of routine. Surgery is only to be done only if endometriosis pain is more, or the endometrioma is very large, or one cannot assess the follicles without taking out the endometrioma. Now coming on to the tubal factors. So tubes, we see in this picture, this is the long curved serpentine tubes which are blocked at both the end. So most of the time tubes get affected, as I said earlier, due to pelvic inflammatory disease. One episode of PID leads to 6% blockage of the 6% block tubes. So it is due to changing premarital world fashions. It is happening quite common. It leads to altered ciliary motility and oocyte transport. Then endometriosis, again because of long number of bleeding years, it can lead to mechanical blockage or altered tubo-ovarian relationship, or tuberculosis, very prevalent in our country, can lead to ciliary damage or block. So regarding the treatment approach, laparoscopy earlier was the mainstay of treatment, either by opening the cornua, doing the stenting, or opening the femoral end. But nowadays it is primarily to look for hydrosalpinx on ultrasound and delink these tubes so that ART treatment is effective and successful. So what about PCOS? Because we know it not only sucks women for her fertile potential, but it sucks feminism out of her and is really depressing with respect to body image. Believe it or not, 50%, it is an epidemic, and every fifth woman is a PCOS and is a major silent killer and the basis of all non-communicable disease, all lifestyle disease, and of course, prevention is the key. But it is very, very important to diagnose PCOS appropriately. It should not be under or over diagnosed because there is so much of overlap with the physiological changes as the disease starts nearly at that time. So it has to be differentiated from functional ovarian hyperandrogenism, adrenal hyperandrogenism, to look for hyperinsulinemia, look for different phenotypes, and define PCOS if it is fitting into criteria. No single test is diagnostic. So these are criteria by ICOG guidelines, which says that between menarche and first year, it is difficult to diagnose. At second year of menarche, if the menstrual cycle is more than 90 days or between 21 to 45 days, or primary amenorrhea 3 years post-thelarche, and hyperandrogenism, which may be clinical or biochemical. And after 3 years and 3 years post menarche, it should be like 21 to 35 days cycle or less than 8 menstrual cycle in a year. What is very important is not to use pelvic ultrasound for the diagnosis of PCOS in adolescence, because we may overdiagnose and multicystic ovary may be labeled as polycystic ovary. We all know that it is a diagnosis of lactation. So kindly mute by someone's mic is. So we have to really differentiate it from thyroid disease, hyperprolactinemia, non-classical congenital adrenal hyperplasia, Cushing, adrenals, hypogonadism by doing various tests. So it is important to differentiate which type of PCOS we are dealing. Is it obese or lean or the four phenotypes so that we can treat adequately. So is PCOS completely preventable? I would put the word yes, because genetics, lifestyle, neuroendocrine, obesity, everything can be prevented. Let us see how. Lifestyle measures and environment have a huge impact in correcting the PCOS, same way obesity. And neuroendocrine behavior, again, it is corrected through the counseling sessions and changing the lifestyles. And genetics has a huge role. So I'll come to this later on also. So it is not only a gynecologist who deals with the patient of PCOS. I think all my colleagues, they deal with PCOS, be it reproductive endocrinologist, primary care provider, pediatrician, adolescent health clinic specialist, cardiologist, psychiatrist, medical endocrinologist, everyone. So how genetics affect the epigenetics, and it carries transgenerational. If a mother is PCOS and diabetes, it affects the adrenal system, the pancreas of the baby, and everything carries forward. We know the Barker's hypothesis also. So it goes along the generation. So all the risk factors, genetics, epigenetics, diet, environmental toxins, sedentary lifestyle, obesity, they give this PCOS, and it has to be identified with its clinical features. It affects every system. So when a young or adolescent girl is diagnosed as PCOS, we have to not only talk to her very, sensitively, we have to talk to her, not to scare her, but just giving her the reflections, like what all it can lead to, the short term and the long term implications in a very smooth way, very non judgmental way. We have to talk to them smoothly. We have to tell them that it can have metabolic and uterine implications later on. Apart from infertility, it can lead to endometrial carcinoma in 10%, and metabolic, we all know, hypertension, atherosclerosis, cardiac events, GTM, diabetes, and hepatic steatosis. So, well, the principle of treatment is motivation, positive attitude, and confidence with a lot of psychological support in changing the lifestyle, and then only comes the medical treatment. Diet is high protein and plant-based, low carb, high fiber, unsaturated fat, and a lot of minerals. It is basically the medical nutrition therapy. Choose oat-based cereals, whole grain breads, make a combination and colorful plate, low GI grains, hypocaloric diet, replace avocado from butter, olive oil, canola oil, non-caffeinated fluid or low carb intake, and select monosaturated fats, then trans fats. Replace salt with fresh herbs. And meaning thereby the Western style of diet has to be replaced by Mediterranean diet. We know that Western diet affects the HPO axis and it is not gut friendly, whereas the Mediterranean diet is very much gut friendly, and we know that it has a lot of neuroprotective effects also and is less inflammatory. So, well, friends, the physiological and the natural way can restore ovulation in 10% if 5 to 10% of weight is lost. And recommended intensity, recommended exercises 150 minutes of intense physical activity and muscle training. So, but it is very important that one has to be regular. It should be brisk walk and power yoga, aerobics, and muscle training. Yoga, especially pranayam, Kapal Bharti, Anulom Vilom, Ujjayi, and Shavasana, it definitely helps. What matters is the approach. It has to be specific, measurable, actual, regular, and time. And exercise, how does it affect the metabolic condition? It reduces the central fat, that is the visceral obesity, improves insulin sensitivity by 71%, and reduction in LH levels. So prevention can lead to not only resumption of menstruation, but ovulation, spontaneous ovulation and conception, and prevention of lifelong complications. So, but if the medical therapy, if the diet and exercise fail, we need to restore to medical treatment. But before we stimulate these patients, we have to be very, very particular about this HPO excess and understand these hormones very well, because we know that these are anovulatory cycles, but it is having high LH, more follicle, high MH, high A2, and the margin of safety is very low, and there is very high risk of OHS. So the choicest drug is letrozole, which leads to increased secretion of gonadotrophins by low estradiol, by decreasing the peripheral estrogen levels. And very important that it leads to monofollicular growth, cost effective with short half life, and it has positive impact on the endometrium with no cumulative action. Then we know letrozole is very, very safe. And very importantly, there is no ovarian hyperstimulation, no increase in ovarian cancer, which is a concern with use of clomiphene more than 6 cycles, and no multiparity. So then letrozole wins over clomiphene, we know that. But when we stimulate with gonadotropin, a very important word is that we should be reaching the FSH threshold very judiciously. And once we have reached that threshold by giving more number of gonadotropins, we need to decrease the dose so that we do not land up in OHS. So it is very important whenever we are stimulating patient of PCOS, we aim at singleton live birth. And uh, even if we stimulate, even if by chance patient is hyper responder and we get over response, it is better to segment the cycle, freeze all the embryos and transfer in the next cycle to prevent the multiple pregnancy and ovarian hyperstimulation. So we know that obesity, hyperinsulinemia, and PCOS are very good friends, and all of them have underlying joining factor, that is gonadotrophin resistance, increased gonadotrophins, low oocyte recovery, poor embryo quality, endometrial receptivity, high miscarriage, and low pregnancy. So the first change has to be through change in the lifestyle, through diet, yoga, exercise, relaxation, and non-sedentary. Nowadays, in morbid obesity, upcoming is the use of GLP receptor agonist and SGLT2 inhibitors along with metformin, though our first emphasis is always on lifestyle change and then metformin. And if it is morbid obesity, along with the endocrinologist opinion, we definitely can go for these. A word about fertility preservation. So, though there are proven results of fertility preservation, and especially in oncological patient, and that is the need of time also. And in fact, nowadays, if someone is dealing with oncology and we do not make a mention about fertility preservation, there can be a medical sue later on also. And for non-oncological, premature ovarian failure, autoimmune disease, endometriosis, infection, and very important is social freezing, which has not yet taken the desired stage. Although it gives a couple, it gives a woman to have her own genetic child. Somehow it has not been very prevalent in even in metros, because maybe probably because of the cost factor or a waiting phenomena that aaj nahi to kal we will have our own genetic child. This is now coming on to the workplace hazards. As I said, electromagnetic radiation definitely and adversely affects the male fertility to a very good extent. It decreases the count, viability, and leads to DNA strand breakage. Same way it affects the ovary and the uterus also. This is electromagnetic radiation world we are living in. The DNA free radical load increases, which in uterus as well as ovary, which leads to inhibition of cell growth and DNA disruption. What about smoking and alcohol and other things? It affects the sperm parameters right from head to toe. Everything is affected. And not only it leads to non-conception, but miscarriages and long-term impact. The drug culture leads to increased oxidative stress and affects the sperm parameter. Now, where is everyone's role? I would start with pediatrician first, because pediatrician, they have a very good follow-up, as they know the maternal profile, whether the mother had PCOS or she was on metformin or she had GDM, what's the weight of baby, what was the growth curve. So they observe the growth curve after birth very judiciously, and if someone is gaining more weight, they make a mention of it, and that is a forerunner of PCOS, we know. Then hormonal issues also they understand. They understand, deal, and make a mention, so that we can deal with these cases later on very judiciously. Undescended testes have to be operated in time. Then same ways, CB, congenital absence of vas deferens has to be made note of. Hernia and hydrocele surgeon, the operating pediatric surgeon, should be like careful and make a mention to the mother that when the boy achieves gets married, this factor should be looked into. And of course, the patient of recurrent pain abdomen has to be addressed, as I said, endometriosis. Now, there are certain things which are very peculiar to adolescent care clinic, like severe pain abdomen, maybe endometriosis or torsion ovary. Puberty, right time to check and counsel for hypothyroidism, to rule out other hormonal problems, as I mentioned, to exclude PCOS. Then obesity should be treated. It's the soil of all the illnesses, right from there point. Same hirsutism. Then if there is history of absenteeism, the drug loop has to be traced, which is very much common in youngsters along with the peer group. The habits, they have a long-term impact on fertility apart from the general disease. Klinefelter, it makes a mention, because Klinefelter is diagnosed just by appearance, and if someone knows that Klinefelter, we know if we can preserve their sperm at early age, it is possible to have their own genetic child. Otherwise, it is not possible later on. Of course, amenorrhea, the underlying disorder, should be treated and make mention, so that their fertility can be restored as much possible. And same way for Turner mosaic, their fertility can also be preserved. Any of them presenting to physician as obesity, high blood pressure, abnormal lipid profile, or early onset diabetes or mumps should also be made a mention. Now, a little bit about male factor also. One quick look tells us whether it is the normal or the abnormal sperm count. And we know the most of the things have come up new as the male factor in fertility has increased. Say for lifestyle factors, they are all treatable, they are all preventable, and then prevention leads to restoring the sperm count so effectively that we need not give antioxidants, because most of them have an impact on the sperm function. Same way, other issues, like if there is no diabetes, there is no point, there are no cases of retrograde ejaculation. Of course, the patients of spinal cord injury or prosthetic surgery have to be managed accordingly. The hormonal issues do come with obesity. So nowadays, that androgen estrogen ratio is very important, and if there is hypogonadism, that can also be treated with gonadotrophin injection. The blockage of the vas deferens can be very well managed with the help of urosurgeons, and if it is not treatable, then we go for ART measures. Amongst the ART treatment, I'll make little mention about everything. The IUI is needed if there is unexplained infertility, endometriosis, or cervical factor or immune factor. Of course, laparoscopy and hysteroscopy has a place in managing and treating the cases of infertility. Almost 38% factors are unexplained, and laparoscopy and hysteroscopy does give a way out. As I said, in tubal, the role is mainly for clipping the hydrosalpinx. PCOS drilling nowadays is not longer used as the primary method of treatment, though it improves the ovulation rate and it decreases the injection requirement and gives a single pregnancy without OHS and natural conception most often. Endometriosis, of course, it is never completely curable. We know that recurrence of 30%. But then modified cystectomy, if there is underlying lesion, which is like severe pain or follicles are not approachable. And if there is a uterine anomaly, it has to be treated by hysteroscopy. And one has to wait for 3 months before going for further treatment. So what all matters is the timely treatment, be it tubal endometriosis, ovarian, advanced stage, or previous failure. And there are certain indications of ICSI in male factor and non-male factor. So approach to treatment is actually the road to success, and it comprises of listening and counseling, which is the core component of doing infertility treatment. Always treat the couple, not individual, and treat all components simultaneously. It is very important. You cannot treat male factor 1 and then you start checking tubes. Everything has to be simultaneously, and we need to have empathy, precision, and treatment according to the guidelines. And very thankful to all of you for your precious time at this moment. Thank you so much. And I'm open to any questions now.
Thank you so much, Dr. Ritu, for such an exhaustive talk. And I think you've covered all the topics, and that's what this platform is for. You are speaking the role of pediatrician as well as surgeon and as well as all the general practitioners who come across such cases. And I have noticed that so many people from outside Haryana also have joined. I truly welcome them all to our future sessions also. And you can unmute yourself and ask your questions, whoever wants to ask. Dr. Karan, you want to ask? Unmute yourself. In the meantime, I would request Dr. MP Jain sir to speak a few words on today's topic, which has been so nicely covered by Dr. Ritu.
Thank you, Dr. Ritu. Thank you, Dr. Kavita. The concise form of infertility causes and treatment, Dr. Ritu has really touched upon each and every topic, and it was very nice to hear. And I hope all of us must have been benefited by this. So if there are any questions, they are welcome.
Hi Ritu, I'm Dr. Alka. Hello.
Hanji ma'am, good evening.
Ritu, as usual, very fantastic talk. मेरे को तुम्हारी talk miss करने का मन ही नहीं करता because you do extensive research to
Thank you.
present a very normal topic.
Hearing from
And
you means a lot to me, ma'am.
that's really appreciable from you.
Thank
And then I just asked that if some patient like adolescent और
Yes,
हम उसको endometriosis जब diagnose के phase में होते हैं,
Hanji ma'am.
so क्या हमें उन्हें ये counsel करना चाहिए कि go for early marriage?
Yes, ma'am, that is it. That is very important. In fact, if we find that if girl is, if she's very young, say 12 or 13, she has just attained menarche. So it is better
हाँ,
to talk about all these things to parents and
जी.
to give them a brief overview of the disease and how it progresses,
Hmm.
that understanding.
Hmm. Yeah, I
And
think it's better.
and nowadays time, because when career has become so important, so the option of
Hmm.
site freezing always remain option open. Otherwise we can give her OC pill so that there is less of estrogen pouring into the
That's fine. Yeah, yeah. But I think still the patients are, or the
not
crowd
much
is not so
receptive, ma'am,
educated.
not much receptive. Yes.
Yes, yes. Because otherwise they say, अभी कहाँ से pregnancy, अभी कहाँ से शादी की बात की हो? People are doing just, the
Yeah,
girl is
that's
very,
why if a girl is
uh,
18, 19 years, it is better to take her
yeah.
or to conversation. Otherwise we
So
can.
I think you take initiative कि कुछ ना कुछ protocol बनाओ for these type of patients ताकि वो अपन उसको OPD में रख लें after the 18. And
Yes,
then we can
yes.
explain them nicely. But very well touched. There is nothing that you have not talked about.
Thank you, ma'am. Thank
Nice.
Good evening, ma'am.
Good evening. Yeah.
Ma'am, I just wanted to know what is the cost of freezing oocytes? The
Ma'am,
current cost in
it cost 50,000 for one cycle. And then if a girl or couple wants to keep it, added on, then it is, I think, at my center, I can tell different centers have different. It is 1,000 per month after 1 year. Because if they keep freezing for years together, sometime we do
Right.
freezing, like I
Right.
do quite a site freezing and embryo freezing also.
Right. Thank you.
Thank you, ma'am.
Uh, Hello, good evening, Dr. Ritu, Dr. Pramila.
Namaskar, ma'am. Thank you.
Excellent presentation, as always.
Thank you, ma'am.
You have touched all the topics. इसमें हमें सिर्फ ये देखना है कि what we need we need public awareness also. We
Yes,
know
ma'am.
all the factors.
Yes,
Late marriage, late planning of the family, and then premarital, what you told about leading to PID.
yes, ma'am.
These things we all know, but I think we need to make the public aware that how important the biological clock clicks on, because
Yes.
the patients are not ready to listen to you. So we have to, I think the role of media is important, or public awareness is very important in this regard.
Yes, ma'am. I'll talk to you, ma'am, and we'll do something. We'll talk.
Yeah.
Thank you, Dr.
Can
Pramila.
you elaborate a little on this thing for beside metformin, the management of obesity, morbid obesity?
In morbid obesity, first lifestyle and this on we know
Yeah,
that
yeah. Beside those
cannot
drugs
change.
which have
Yeah,
come,
cannot change.
because
Yeah.
majority of the drugs which came, they were hepatotoxic
Yes, ma'am.
previously.
So that is
So
I made
are
a
they
note.
FDA approved? Any drug approved for treating obesity, morbid obesity?
No, this Orlistat had been approved earlier, but we are as a practitioner not really using all this. And if it has to be used, it should be in consultation with the endocrinologist. This is what I believe. Because nowadays we know, and it is not easy for us to follow up for all these also. And especially liraglutide and all the dosage has to be adjusted by the endocrinologist.
Okay. Thank you.
Just a small comment, Dr. Pramila's question.
Yes,
Can I,
sir.
ma'am?
Yes, sir, please.
Yeah, so nowadays, ma'am, the lifestyle modification, of course, we all advise, and sometimes it fails miserably. So escalation of treatment has happened. Semaglutide was available in the oral form in India and in subcutaneous form in all across the world, from Dubai and Singapore, with the name of Ozempic. But latest introduction is tirzepatide. Tirzepatide has come with the name of Monjaro. It has led to around 15 to 20 kilogram of weight loss. The weekly subcutaneous injection, you start with 2.5 for 4 weeks, and then you escalate to 5 milligram after that per weekly. Yeah, if I mean, in a desperate situation where person has tried everything and obesity is leading to metabolic syndrome and all other complications, and who don't want bariatrics or endoscopic methods or balloons, or, I mean, this is one of the options which has recently been introduced. So
Any side?
tirzepatide, yeah,
Okay.
tirzepatide.
Just I want to interfere that since I'm in US, my daughter was telling she's a physician. So I asked, especially for the weight loss, the America also has banned this drug now to be available for the patients for the weight reduction. That is only for diabetes.
Tirzepatide is just introduced. Is Monjaro with the name of Monjaro. It is a tirzepatide.
Monjaro is before Ozempic. You will not believe it.
Yeah, in India. In India, it's introduced.
Yeah.
It's a dual inhibitor.
Yeah. But,
Actually it's acts on both GLP and the gastric inhibitory peptides. That's why action is little better.
when it was given, it was really a very good drug for the weight reduction. No?
The only problem is
Any
GI
side effects of this? Any side effects?
Always.
Pramila ma'am,
Always
GI
side
side
effects.
effects are common. In the first 2 weeks, you have to manage nausea, you have some distension because it decreases the gastric emptying. So
Okay.
some kind of bloating, but then weight itself has so many problems. It's the biggest evil at this time. And let's accept that some patients are not able to lose weight because of many reasons, maybe because of metabolism and others. So unko as a person accept karke, I mean, you can offer. So that subgroup of patients who are not able to lose weight otherwise.
So I think, sir, you brought a very nice point, and actually we should not be treating these patients individually with the endocrinologist and with you people only as a group.
Yeah. So obesity, metabolic syndrome and obesity, it's a team concept, definitely.
We cannot manage individually because they need input from every angle.
Yes. And more, ma'am, we should accept. Many times we don't accept that people are not able to lose weight. If
Yes.
there is a efficient effort put already by the person for 6 months, 1 year, did everything, dietary modification, and in post-menopausal women who are at 58 to 60, knee not working, it's very difficult to have that much of calorie loss with physical activity. And those people should be taken into account. And those are the people who are prone for metabolic syndrome, fatty liver, cirrhosis, and whatnot. So I think that subgroup needs more attention with the pharmacotherapy.
Yes, sir. Yes, sir. True.
Dr. Rahul, there was a paper on retinal side effects of this GLP-1 analogs. So, do you have any comment on this?
Yes, sir. It was very rare. It was noticed with semaglutide. Tirzepatide, I'm not aware of anything which can be seen. At least I'm not aware of.
And about tirzepatide, basically, there were some side effects like depression and suicidal tendencies.
Sir, extremely rare, and believe me, I mean, such a senior physician, मैं ही senior also. Obesity से बड़ा तो कुछ भी नहीं है, sir, इस वक्त, We have to weigh the risk and benefits.
Perfect.
Very rare chance. अच्छा, pancreatitis में भी ना, sir, it was very rare. People have labeled that gallstone होंगे and pancreatitis होगा, but the incidence is not high. And see, obesity itself is the highest risk for gallstone in any which way.
Yeah.
Hello, ma'am.
Hello, sir.
My name is Dr. Vishwas. I joined a little late, sorry.
Yes.
But, as a general physician, I would like to just ask you, because people get attracted to that one line that the IVF centers, pronouncedly claim success rate. So how exactly this success rate is standardized? Like, what is the definition of success rate? Is it the conceiving thing that is getting converted from an infertile period to having a successful pregnancy episode, or whether it is a continuation of a pregnancy after the IVF success procedure? So how do you calculate this success rate?
Sir, if you ask me truly, I think it is the journey from two lines to two lives. That is what I perceive. If we give a live birth rate, to me, that is the success. Chemical pregnancy, ectopic pregnancy, or if the pregnancy gets terminated in between due to some chromosomal, I do not count it as success rate. Although, if we go by our literature, having a beta HCG value more than 20 is considered as a IVF conceived patient. Then what matters is the ongoing pregnancy, live birth rate. That is, we whenever we take success rate, we take all these criteria differently.
So is it
It
like a
depends on the indication for which the IVF procedure has been done. It will vary. Suppose it is done for a tubal factor in a young patient, the success rate can touch to as high as 70%. So in the first cycle, suppose it is done for a patient who is 40 years of age with a low ovarian reserve, the success rate is actually 20%, 10 to 20% with her own eggs, and she may need more cycles. If it is say for endometriosis, again it will vary between 40 to 50%. And nowadays the trend is to do more of freeze cycle and transfer of single blastocyst, which is giving less complications during pregnancy. And also with that, the success rate is 35 to 40% in one cycle, if you ask me the actual thing. And a couple may
Okay.
need a
Of
couple may
course.
need 2 to 3 cycles to get a healthy pregnancy out of her own genetics.
Right. Actually, this is what is, unnecessary. A lot of competitive claims have been made, and IVF centers are, attracting on this particular thing, success rate, and people are get attracted because of the, 95% rate, 97% rate, like that. All those.
Best of the centers in the world also say it is, and all the papers from ASHRAE, ASRM also say that it is between 45 to 57%. And how can we claim more than that?
Yeah, if somebody has two and both are pregnant, I mean, achieved the pregnancy, they might have say 100% because
Correct.
they have done only two in their lifetime
No, sir.
and they are a new practitioner. So it's very misleading information,
We should go
actually.
by actual facts, in fact.
Hmm. So in general, it should be for the faculty. The success rate should be of the faculty, not the individual gynecologist. You
Yeah,
see,
it's from the center, and our ISAR association had calculated it from as under the banner of Nari, and they had presented the data, and that also had the success rate of India from 46 to 57%.
hmm. So, I mean, in general, it should be like that, that this is a procedure and this has the failure also. I mean, so that is how, it should be told upfront. Otherwise, we have burned fingers by, referring patients here and there. And
No, so
then people,
nowadays there is a proper counseling sheet depending upon what is the indication. We tell the patient because patient is so well educated, they know and they should know that how many cycles do they need to get a pregnancy. And otherwise, also in this medical legal era or the type of atmosphere, medical atmosphere, if you say 100%, it doesn't turn up, the patient may come up with the fight next moment. So it is not really practical also.
I'm little late, but have you covered the surrogate mother part of it?
No, sir. I thought because we
Sure.
are dealing with preventive part of infertility
Correct.
and a treatment approach.
Right, right, right. That is also becoming quite popular nowadays. Anyway, but I must say that this is a very crucial topic, and infertility, which we are seeing, is rising very high. As you said rightly, that the career decision and etc. have been on the priority of the young women, and the marriages are also late. There is a lot of period that they, want to take to get first pregnancy, etc. So all these things, first they don't want, and then they struggle for having it like anything. They are just after it. So these are two extremes that is happening in one's life in that age group. That is what we see.
Thanks.
But yeah, definitely we will refer something like if comes on the way.
Thank you, sir.
Okay. Thank you.
If there is no question, can we wind up the session?
Yeah, I
Dr.
request Dr.
Pawan?
Pawan Goyal to please say a vote of thanks.
Thank you, Dr. M.P. Jain, sir. Thank you, all the seniors and dear colleagues. And the special thank to our learned speaker, Dr. Ritu Jain, who presented this topic in such a wonderful way that it became very, very interesting as well as very informative to all the delegates present here. And there is again one more request. Please circulate this message that we are conducting this CME every Thursday, same time, at the same place with the same link. And we'll be bringing some more new innovative topics to you. And please circulate this message so that more and more people join this meeting. And it will not only enhance our confidence in conducting such sessions, but it will also enhance the knowledge of our delegates. Thank you, everyone. And let's see you again next Thursday on some more interesting topics. Thank you. Thank you. Thank you.
Thank you, Dr. Pawan. Thank you, Dr. Kavita, and everyone who attended. And thank you, Dr. Jain.
Good night. Thank you.
Good night. Good night. Good night, everybody.
Good night.